I want to welcome everyone to another edition of Controversies in Cardiology, in which we have the opportunity to have a really very lively panel discussion on an important topic in cardiology. Let me just remind people that they can archive previous talks. They can find our archives of previous talks on heart-talks.org. We have all of our prior panel discussions of this past year and a couple from last year on that site. Let me just tell you a little bit about the format. This is a panel discussion in which the moderator will ask the panelists quick questions about case scenarios in this particular format. Dr. Vivek Reddy is going to be the moderator. We're very privileged to have Dr. Andrew Epstein as our visiting professor, and Dr. Fuster will introduce him more formally. I just want to give you a preview of the rest of the year. Our visiting professors on March 17th is Dr. Joseph Oscalzo. In April 7th, Ken Ellenbogen. May 19th, Dr. David Holmes. And on June 16th, Dr. Chris O'Connor from Duke. Just to give you insight into some other very important programs that are carried on the web on February 18th on CCC Live Cases, Dr. Sharma and his colleagues in the Cardiac Catheterization Lab present and perform very interesting cases live with commentary. And on February 26th, the Cath Lab team led by PK will present very interesting and perform very interesting vascular procedures with commentary. February 18th for Dr. Sharma and PK on February 26th. There is an accompanying monograph which our fellow Ed Lynn had put together, and that should be linked to heart-talks.org site. You can log in for free and see the monograph. Without further ado, I'm going to introduce Ed, who put together a monograph on one of the different topics that will be covered by Dr. Reddy. Ed?
Thank you, Dr. Goldman. I would also like to thank Dr. Fuster, our guest, Dr. Epstein, the panelists, and everyone here for the opportunity to speak here today. So the topic that we're going to start with in our panel discussion is the device therapy and the prevention of sudden cardiac death after a recent myocardial infarction, specifically the role of implantable cardioverted defibrillators and wearable cardioverted defibrillators. Sudden cardiac death poses a significant health problem, as some estimate that it causes almost 500,000 deaths every year in the United States. The highest risk of sudden cardiac death occurs during an acute myocardial infarction, but even after the event, the risk remains substantially elevated, particularly in the first several weeks to months, and declining as time passes from the event. This period of vulnerability represents a good target to attempt to reduce sudden cardiac death. Revascularization strategies and medications have helped to reduce both overall and arrhythmic death, but cardioverted defibrillators, whether implantable or wearable, may also play a role in the setting. Outside of the acute MI period, there is solid evidence for the role of both secondary and primary prevention ICDs based on AVID, MADE-IT2, SCUD-HEFT. But in the setting of a recent MI, the data are not as convincing. So with secondary prevention devices, the difficulty lies in the question of whether early ventricular arrhythmias post-MI are due to reversible causes and how likely they are to recur. The mechanisms of ventricular arrhythmia within the first 48 hours differ from the mechanisms after 48 hours. Whereas late arrhythmias are typically attributed to scar-based reentry, which is a more permanent substrate, early arrhythmias are driven by ischemia, which are often kind of a temporary milieu that may not be recur. The presence of early ventricular fibrillation within the first 48 hours post-MI has not been conclusively shown to increase mortality after hospital discharge, while late ventricular fibrillation has a more clear mortality effect. Therefore, recommendations typically do not recommend placing secondary prevention ICDs in the setting of ventricular fibrillation or polymorphic VT if it occurs within 48 hours of MI. However, specifically with monomorphic VT, it may not have a clearest distinction between early and late recurrence. And this is because even VT that occurs early can be due to more permanent scar and can be associated with increased long-term mortality. So there's still some debate on what to do about early monomorphic VT. Now moving on to primary prevention devices, although sudden cardiac death is clearly increased in the first several weeks after an MI, the evidence has not shown any benefit of ICDs during this time period. The Dynamite trial enrolled patients 6 to 40 days after a myocardial infarction with EF less than or equal to 35% and showed no difference in mortality with primary prevention ICDs. There was a decrease in arrhythmic deaths, as expected, but it was balanced out by an increase in non-arrhythmic deaths. The IRIS study showed similar findings. The reason for this lack of benefit is not completely clear. Part of it may be due to that the patients who have sudden cardiac death prevented by the ICD may still die due to recurrent ischemia or structural complications which induced the arrhythmia to start with. One autopsy study showed that sudden cardiac death after MI, only around half of the deaths were due to a primary arrhythmic event. Because of these results, guidelines have established a 40-day post-MI waiting period after an MI if no revascularization is performed, and 3-month waiting period after MI if revascularization is performed. These mandates are also mirrored by the National Coverage Determination, which dictates reimbursements. Perhaps the biggest controversy regarding post-MI device therapy is the role of wearable cardioverter defibrillators during this waiting period. The most recent and largest study was by our guest, Dr. Epstein, looking at over 8,000 patients with recent MI and depressed EF who were issued a wearable cardioverter defibrillator. 1.6% of the study population had appropriate defibrillations with a greater than 80% success rate of terminating the ventricular arrhythmia. However, one of the biggest drawbacks is patient comfort due to the size and weight. The Wear It BiRod trial had over 20% of the patients withdrawing from the study due to discomfort. Although these findings suggest that there may be a small population of high-risk patients post-MI which could potentially benefit from wearable cardioverter defibrillators, given that there's no benefit in ICDs in this time period, it's unclear how these wearable devices will fare differently. There may be a role for risk stratification to identify the population who may most benefit from the wearable cardioverter defibrillators. But currently, there are no randomized controlled trials that support widespread use, and formal guidelines are not helpful at this time. There's an ongoing trial called the VEST trial, which will randomize patients after an acute MI with EF less than or equal to 35% to wearable cardioverter defibrillators versus conventional management, but it won't be completed until 2015. Until then, the widespread use of cardioverter defibrillators wearable is still controversial, and clinical decisions will have to be made on a case-by-case basis. Thank you.
Thank you, Ed, for a very nice presentation and certainly a nice monograph about a subject that, as you mentioned, is very controversial, but we'll see if we have some light today. So the visiting professor today is Dr. Andrew Epstein, who actually was born in New York, and he has been around the country, north, south, east, and west almost. Was born in New York. He attended a good college, Amherst College, Massachusetts, and then he went to the University of Rochester School of Medicine, where he obtained the degree, the MD degree. Then he moved to St. Louis, where at Barnes Hospital, he had the opportunity to be an intern, a resident, and then a fellow in cardiology, and then she was the chief cardiac fellow there. In fact, I made a mistake. He moved from the residency in internal medicine to a fellowship program at Birmingham, Alabama, where he did the whole cardiology training program, and then he became chief fellow in cardiology. Now, his curriculum is quite dense, And just to mention that in Birmingham, Alabama, very rapidly, he moved from assistant professor to professor of medicine. And then he became chief of cardiology section at the Department of Medicine. Then this was in Philadelphia, now at the University of Pennsylvania. So the move from Birmingham to Philadelphia took place actually in 2009, and he has been there since. Now, among the accomplishments that I can go over, and I don't have much time for the detail, he got all the awards possible in terms of education in the different institutions that he has been. And I will also mention that aside of this, he has been in the editorial board of the main journals in electrophysiology, as well as in the American Journal of Cardiology and Journal of the American College of Cardiology. Now, of great interest, he has been in committees, in 50 committees related to clinical trials. There is no trial, it seems to me, on devices or intervention in electrophysiology that he has not been part of, either as an investigator or in the surveillance committee or any kind of committee, and there's no actually trial that his name is not there. So he has been really very active on clinical trials, and today he gave a beautiful presentation about both aspects of trials, those that are critically important and those that are very questionable, which are many. So in terms of his contributions, scientific contributions in the EP field are tremendous, as you can imagine, having been a participant in so many trials. He has almost 300 publications, and really has any subject that relates to devices or interventional, whether it's ablation and so forth, his name is there. So it's a pleasure to have you here, Andrew, today as a visiting professor. All of us appreciate very much the wisdom to come, and I'd like to give you this plaque for you to remember, okay? For Andrew Epstein, expression of appreciation for all of us. And you, Anandi Sharma, visiting professor, is related to the father of Dr. Sharma. And then Simon Duck, that you probably remember. And this is the Simon Duck Memorial Lecture. So I give you this, I give you a check. I don't look how much is there. But the most important, you to be here. It's a pleasure.
Thank you so much.
And now we are going to ask the protagonist of this controversy. You can sit over there, Andrew, in the middle. And I'm going to Dr. Ducati, Tony Gomes, Dr. Pinney, and then, of course, Dr. Edward Lin, and then Dr. Vivek Reddy is going to be the moderator today.
Okay. So I'm just going to adjust myself here a little bit. Okay. So first, I want to thank Marty again for allowing me to participate in this session. It's wonderful to have Dr. Epstein here. He's been involved in many of the different topics that I'm going to try to touch today. Let's start off with Dr. Lin's topic, which is defibrillator therapy or prevention of sudden death soon after myocardial infarction, which is an excellent monograph, by the way. So as he explained, the risk of death is high soon after myocardial infarction. We know from the Valiant studies and other observational studies. We also know from two relatively large interventional trials looking at defibrillator therapy versus not defibrillator therapy, that defibrillators are not the answer, at least they're not the whole answer. we heard about the Dynamite study and the IRIS trial. Remember, the Dynamite and IRIS, they both looked at patients soon after myocardial infarction. In Dynamite, patients additionally, in addition to low ejection fraction, they had depressed autonomic function. In IRIS, they either had low ejection fraction or they had evidence of ventricular arrhythmias, not sustained ventricular arrhythmias, but non-sustained VT on Holter monitoring. And those patients were randomized to either defibrillator or no defibrillator. And what was interesting, first, the overall endpoint of all-cause mortality was not different in either study. The hazard ratio was close to 1, so there wasn't even a trend toward benefit. But in both studies, as Dr. Lin points out in his monograph, in both studies, there was almost a 50% reduction in sudden death, counterbalanced by an increase to non-sudden death in those patients that received the defibrillator. So I'd like to start here, and let's start off with Dr. Epstein. Just if you could help us think through why would this happen, just from the pathophysiology. What are your thoughts in terms of just physiology and what you expect?
Thank you very much, Vivek, and again, Dr. Fuster and everyone. It's a great privilege and honor to be here, and thank you. I think there are two aspects to an explanation, if you will, for Dynamite and IRIS and the lack of benefit for early device implantation. One is that the substrate early after infarction is not fixed and it's changing, and the mechanism of arrhythmias, I think, is different. They're not just reentry circuits, but there's cellular changes, ongoing ischemia in people who are not fully revascularized. So the efficacy of an ICD, the way we usually think about it, is terminating an arrhythmia for something that's fixed substrate isn't there. Second of all, the mechanism of sudden death, sudden cardiovascular death, early post-infarction, is not all arrhythmic. And Ed alluded to this from Valiant, which you also mentioned. Very interesting sub-study from Valiant was published in Circulation. The first author was Poullaire. And they had the opportunity to look at autopsies in a subset of patients who had those done from the study. Interestingly, the Soviet Union was part of that trial, and they mandate autopsies to be done. So they had a big volume of posts from that population. Out of the 104 patients, I believe, in the study, 50 of them had non-arrhythmic causes of sudden death. And clinically, the phenotype was sudden death in all these individuals. And so it was myocardial rupture, recurrent infarction, and non-arrhythmic causes. Wouldn't expect a defibrillator to help those people. And then finally, I think, and this is a bit nihilistic, but it's true, Paul Dorian looked at the Dynamite data, and this is published also, and it's very interesting that for the people who received defibrillators who didn't receive shocks, they had the identical survival as they had better survival than the control group. All of the people who died in Dynamite were people who received shocks. So all that the defibrillator did was to convert sudden arrhythmic death to non-arrhythmic cardiac death. And I think these people are unfortunately destined to pass. Mm-hmm. And there's, in the absence of a left ventricular support device or an artificial heart, their hearts are just too poor to survive. Remember Dynamite, these were exactly the patients that all of us worry about. 70% of them had anterior infarctions. The mean CK was over 2,000. These are the people that are at high risk for arrhythmic and non-arrhythmic death.
So I think certainly one of the questions is whether or not the defibrillators themselves, if you could implant the device without causing the morbidity associated with defibrillators, including right ventricular pacing, because that was also one of the questions, right? Whether or not defibrillator implantation, the pacing associated with defibrillators, the ATP delivered, et cetera, may be worsening mortality. So I guess the question is, what do you think about the wearable defibrillator in this context?
It has never made any sense to me why, if an implanted device doesn't save lives, why an external device should. I've seen hundreds and thousands of patients with defibrillators and been involved in all the trials, as Dr. Fuster said, and there's never been a signal that the implantation procedure itself has hurt people.
Right.
And in fact, despite the literature that's available suggesting or indicating that people who have shocks have worse survival, there's controversy about whether or not it's the shocks themselves versus the substrate that is responsible for mortality. And in fact, even with antitachycardia pacing, has been shown by the Mayo Clinic, ATP without shocks, 4VT, is associated with worsened outcome. So I think it's a substrate problem and not the fact of shocks. And if shocks are not the problem, then an external device versus the implanted device shouldn't make any difference.
So I want to come back to the shock issue, but just finishing with this, Edward, maybe you could just comment a little bit about the VEST trial. I tend to agree with you, but there is a trial that's ongoing that's looking at this particular issue. Edward, do you want to just comment on what the VEST trial is and how it's designed?
So right now the main problem is the absence of randomized control trials. So most of the wearable cardioverter defibrillator trials we have are kind of database looking at all the people who have them currently and seeing kind of who, and we know from that data that they're effective in what they're meant to do. They can terminate arrhythmia, but the question is the arrhythmia that they terminate, would that have caused mortality? And even if they do terminate the arrhythmia, are they going to still die? So those don't solve the question of whether the wearable cardioverter defibrillator is actually causing a mortality benefit. So that's where a randomized control trial will be very helpful. The VEST trial is the first one of that, and it's scheduled to kind of end around September 2015, but it's a randomized control trial looking at people after acute MI. I don't remember the exact data, but either they're enrolled during the hospitalization or within a couple days after the hospitalization after an MI. And you randomize, and they have to have EF less than equal to 35%, and they're randomized to wearable cardioverter defibrillator or conventional therapy. And I think they're mainly looking at kind of primary sudden death outcomes, but still. Yeah.
And hopefully the trial will actually get completed.
Yeah.
It's very difficult enrollment. I actually don't know where the trial is in terms of enrollment. They'll probably end up having to stop early. Before we move away from the wearable defibrillator, I want to ask Andy a question. There's the Wear It study, which looked at about 3,500 patients, looking at the wearable defibrillators as a non-randomized study. And as Edward pointed out earlier, there were defibrillations in 1.7% of the patients in that group. And there was successful termination of tachyarrhythmia in 99% of the patients. That's what was reported. And then, Andy, your study was about, a little over twice as large, with over 8,000 patients. And again, 1.6% of the population. What was interesting is, in yours, it was successful in 82%, not the 99%. What do you think is the difference? Does this mean something?
Yeah, I think it's because these people were enrolled virtually at the time of their hospitalization of infarction, and this gets to that it's a different mechanism for arrhythmia. So these are not people with a chronic stable substrate that were in Wear It. These are people who were in a changing substrate.
It is a little bit weird. That means if there was 82% termination, so that suggests or about a fifth of the patients had VT in an unstable substrate that was not terminable, right? That means that they had polymorph, they had ischemia or whatever else. That number seems sort of hopeful. Doesn't mean that number is relatively low in this early population.
The usage rate is low, or the success rate?
No, the success rate, the failure rate is relatively low. The failure rate of termination is not that bad.
Yeah.
Right? I mean, that gives some hope for VEST if it ever gets complete.
As I talked about at lunch, this is the difference between absolute risk reduction and relative risk reduction. And yes, 18% failure rate is not bad, but when you look at the absolute number, if only 1.6% of the patients who were
Right.
deemed at apparent high risk post-infarction got the device. And of those, 82% or whatever it was were successfully defibrillated. The absolute number of patients saved is relatively small in a large population sense.
Yeah. So what is the role right now for the wearable defibrillator?
I think
Who should
it's-
we use this in?
I think it's from an aerial view, there are really three populations to look at. One, which is the easiest, is in the post-extraction population for infected devices, and that's easy. I don't think there's any controversy there. It's a bridge to healing of infection and implanting a permanent device. The second population is the newly diagnosed patient with heart failure. And I feel very strongly on this one that there is no evidence that early use of the device provides benefit. There are 3 trials that looked at implantation of a defibrillator early in the or for the management of heart failure. The CAT study was terminated early for futility. The entry criteria for that was heart failure lasting less than 9 months. The second trial was Dynamite. It was a negative trial, and there was no entry criteria for enrollment. A sub-study was done that said there was benefit at 3 months and 9 months, but that study breaks all rules of statistics by looking for a subset with benefit when the overall trial was negative.
Right.
And then finally, the strongest trial is Scudheft, which had a 3-month waiting period for optimization of medical therapy, and the survival curves for the defibrillator broke from control of optimized therapy only at 1 year and 2 months after enrollment. So there is no signal that early use of the defibrillator helps that population. So finally, we're left with the post-MI ischemics in the waiting period before assessment of improvement of ejection fraction. We've talked about Dynamite and IRIS. For me, in the absence of data, I think it still rests at the bedside for the patients with a perceived high risk for an event in the eyes of the beholder, and that is the physician. And I don't think there is a criterion that's right or wrong. I think it's wrong to say that everybody should be prescribed the device. I think it's wrong to say that no one should. It's something in the middle. I just can't draw the line. I can tell you that even though I wrote the paper and you can look at it and say, oh, this guy favors the device or he doesn't, I've only prescribed it twice in my career post-infarction. And one of them was for a patient actually who had a preserved ejection fraction, who had presented with an arrest, single vessel right coronary disease, was resuscitated, no cerebral damage, and on the day of discharge had a 29-beat run of accelerating VT, which seemed to be automatic, and obviously didn't qualify for an implantable defibrillator, but I felt uncomfortable with a long run of VT as he was walking out the door. He got a device. A month later, he had an EF of 55, no events recorded by it, and it was fine.
So let me ask you, I'm just going to present a case scenario. A 60, and this is for several of you. A 65-year-old man, let's say, who presents with an anterior myocardial infarction, presents 8 hours after the onset of chest pain, and the infarct was thought to be complete. A couple days later, an echo shows an ejection fraction of 38%. I know when we get a 38%, but let's just pretend it showed an ejection fraction of 38%. And 5 days later, so 5 days after the initial presentation, while the patient is still in the house, the patient has a polymorphic VT arrest requiring defibrillation. What do we do? Let's start, Andy. Oh, I'm sorry, Tony, please.
For me or
No, go ahead.
But I just want to make the arrest was how many days post-infarction?
It was 5 days.
Okay.
Now, you're probably asking, why is the patient still in the hospital? But
No.
let's just pretend they're still there. Okay.
Not at all.
Our administrators are asking that.
You said polymorphic VT, right?
Yes, but a sustained event requiring external defibrillation.
Before that, can I just say a few words? I don't understand the logic of all this. Perhaps as I'm getting older, I'm getting lost as well. But, what are we trying to achieve? I mean, the implantable, we talk about sudden death. We don't really know the mechanism in that phase of MI, post-MI. The other thing is that why do we expect the ICD to increase survival? It's supposed to only impact ventricular arrhythmias. So we are really assessing a surrogate of, do we expect, though, for the ICD to increase to improve survival? Now, you said that in the 2 studies that he pointed out that there was a 50% reduction in sudden death. But it didn't affect total mortality because probably those hearts are so bad that people are going to die anyway.
No, that's true in the primary prevention trials, absolutely. But when I'm describing a slightly different patient.
Yeah, now this patient that you're talking about.
Who survived, who had an ambient.
He had polymorphic VT, so ischemia is a distinct possibility in this patient. So I would cath the patient first and to find out what his coronary anatomy is, and I would wonder whether I could revascularize him. Since his EF is 38% and he had polymorphic VT, he may be somebody that I might consider putting on a vest.
Okay. So and let's say that the cath didn't show anything revascularizable. But I think you said you want to put a vest in and presumably repeat the ejection fraction in a couple of months.
Yeah, I think that's what I would.
Okay. The difference here, again, this patient did survive a VT-VF event. Well, here, a polymorphic VT event. Srini?
Yeah, I think I wouldn't put a vest in them.
You would or would not?
I would not.
Would not.
So for the one question is polymorphic VT 5 days out. What is the mechanism of that? If it's not ongoing ischemia, one of the things that you can consider is Purkinje PVC-induced polymorphic VT and VF, which is actually quite treatable with an ablation. The Purkinje network in the border zone of the scar can often trigger these acute, in the setting of an acute MI, remote MI. You can have PVCs that are triggered from the Purkinje network that subsequently trigger polymorphic VT. In those cases, an ablation would be curative, and then you send the patient home, maybe a life vest, I don't know, but certainly with beta blockers and other heart failure medications during that time. If you do not see that stuff straight, I would just put an ICD in that patient rather than pushing it down the line.
Okay, so as I move down the line, I want to change this just a little bit. Let's pretend it wasn't polymorphic VT, it was monomorphic VT, 5 days post. Okay? Andy?
From an aerial point of view, it's really easy. When you get past 48 hours, which is the marker that was chosen in the guideline and the appropriate use criteria, this becomes secondary prevention. And ICD is indicated. Now, what you might do... I'm sorry to interrupt. It does, with the caveat that these patients, I mean, there are very few of these patients are actually in the trials. Most were remote MI, but yes. That's right.
Okay.
But it's an ICD plus what else in terms of management and evaluation. In terms of saying, well, this is a Purkinje-mediated arrhythmia or not, I'll go back to our AVID study, and we were very smart when we planned that, and then we kept a registry. And one of the exclusions to be randomized in the secondary prevention study was that we kept a registry. And in the registry, people who were excluded from randomization because they were thought to have had a reversible cause of their arrest had the identical outcomes in survival as did patients who were randomized to non-device therapy in the trial. And this tells us that we're not very good at identifying reversible causes. So whatever we do in this guy, he's going to end up with an ICD. Now, that being the case, I think to think about Purkinje-mediated arrhythmias, to think about ischemia, especially since it's polymorphic, I'd want to know, was there sinus tachycardia before he rested, which would make it Polymorphic VT versus bradycardia, think about Torsade, what was his potassium, what can be fixed. And for your SMASH VT, I would think if it was monomorphic VT as that you were getting into, I would certainly think about going after that if this was clear monomorphic VT and still put in a device. So I would look for reasons, but that wouldn't not put in a device. There are more levels of care than just device or not.
Okay. I want to move on, but first, actually, Sean, do you want to make any additional comments?
No, I'll just throw the medical therapy in there, which is that he should be on an ACE inhibitor, he should be on a beta blocker, and something that we often overlook, he should be on a Plarinone. His ejection fraction is less than 40%, survival of myocardial infarction. He probably went into VT because we over-diuresed him. That's what we do in heart failure. Make sure his K and MAG are repleted.
Okay, I want to ask a question. I've asked this several times during this controversies to several different people, and which is this whole issue. And you alluded to this earlier: are shocks bad? Is ATP bad? I'm going to just quickly go over the two, I think, relevant studies. And I'd like to have Andy, you comment on what you think is going on. There are two important studies that came out in 2012, 2013. The first is MADE-IT. Just to remind everybody, MADE-IT was a very large study that took patients who were indicated for a defibrillator and randomized them to three types of programming. One was conventional programming, which is, well, conventional. The second one was high rate therapy, meaning therapy was only delivered at a very fast arrhythmias. And the third was called delayed therapy, meaning therapy was only delivered after waiting a longer period than usual. That is allowing the tachykard to terminate by itself. Now, what was interesting, and the issue was, the idea was that both of these second types of programming would likely decrease the risk of shocks, and hopefully do that without increasing the risk of syncope. And indeed, that is what happened. But what was also interesting was that there was also a reduction in all-cause mortality in both those groups. And it was pretty impressive. The odds ratio was about 0.5, 0.45 and 0.56. Okay, so what was seen is concomitant with decreased ICD therapy, both ICD shocks and ATP, there was a decrease in mortality, suggesting that what the device is doing, the shocks, the ATP, may actually be bad for you. Then we have the altitude study. The altitude, and this was published recently in JACC. And this is it was a nice study because of basically its size. They looked at the database, and this is also real world. They looked at the database of patients in the receiving defibrillators, and they looked at a lot of patients. It was, 3,800 patients who received the defibrillator and had a shock episode, and compared it to an equivalent number of patients who didn't have a shock. And what was seen was interesting. Consistent with earlier studies looking at the Scud-Heft and MADE populations, patients who received their first shock for monomorphic VT had a subsequently higher risk for mortality. This is not a surprise. We've seen this in other studies. And the odds ratio was 1.65, so 65% increase in mortality. Similarly, patients who had a shock for VF had a higher subsequent risk for mortality. Odds ratio was 2.1. What was also interesting is patients with, so those two pieces of data by themselves, which we've had before, shows only a correlation. We don't know if the shocks are bad for you, or we don't know if patients who have VT or VF identifies a population of patients who are about to die or going to die. Now, patients who had AFib and flutter-related shocks also had a subsequent increase in mortality, 61% increase in mortality, suggesting that maybe the shock is bad for you. But when patients had a shock for an SVT or for lead noise, there was no increase in mortality. So the conclusion from that trial is that arrhythmias identify substrates that are at high risk for sudden death, and even AFib and atrial fibrillation or flutter in a patient identifies a patient at high risk for sudden death. But if you have a shock for SVT or shock for lead noise, it doesn't increase in mortality. So you have two pieces of data that are seemingly conflicting. MADE-RIT that says shocks and even ATP are bad for you, and the altitude, a large study, suggesting it's not bad for you. How do you reconcile this?
To me, I think the altitude data are very strong, and they're in keeping with what I said before, that I think it's a substrate problem rather than a shock problem. when people talk about shocks being bad, they forget that at least in 70% of the devices that get implanted in this country now, we do DFT testing at the time of implant. And there is not a signal there that that is bad. And in fact, in MADE RIT, I don't know the exact numbers where DFTs were done, but I think it's going to be 70% also, because that's pretty much the numbers in the country. It's is a shock during implant not bad, but a shock 2 weeks later bad? It just doesn't make any sense to me. To me, and many of us have asked Dr. Moss what he thought was the mechanism of the decreased mortality. He says, I really don't know. They don't have any cellular or other mechanism. It's just that it's an observation. And I just don't know why. But I do think that from altitude, the fact that shocks for lead noise and SVT are not bad, but whether it's AF or VT or VF, it all makes sense that they would be bad, because people with AF and that kind of heart disease also have maybe having progression of disease. So I don't get real wound up about the mortality risk of having shocks. I do get wound up about the quality of life issues, and that it is having shocks when you're awake is a bad thing.
Yeah, go ahead.
I think that the shocks in certain individuals are certainly bad, and probably represents what we see, poor underlying substrate. And certain people with shocks have really no major effect at all. We see that all the time during our VT ablations when people are in VT, and they're otherwise a healthy individual with the EF of 40-45%. You shock them, and the pumping function comes back to normal almost immediately. Whereas in people who are heart failure, ejection fraction 15%, you shock them for the VT, and it takes a while for the pumping function to come. And as you go on with the procedure, they tend not to do as well as the other people.
I've never thought about it in this context, but all of us have seen people who come in with VT storm or shock because they're in the context of decompensated heart failure. And you diurese them, you tune up the heart failure, you optimize their medical therapy, you decrease the myocardial wall stress, and the arrhythmias go away. And we don't necessarily ablate these people if everything quiets down that quickly and they're in such bad heart failure to begin with. And so that's one end of the spectrum of it's the substrate that's causing the arrhythmia and hence death.
And that's probably what happens in the acute, post-acute MI patient as well. You know, the high mortality related to.
So within this past year, there was introduction of new technology, specifically the SubQ ICD. So this is a defibrillator I think all of you are aware of. Instead of the defibrillator being placed prepectorally with the lead in the heart, the device is placed subcutaneously or submuscularly in the axillary region with the lead that's actually it's all tunneled subcutaneously. The advantage of this device is that there is no intravascular component. The disadvantage of this device is that there is no intravascular component, so you can't pace the heart with this particular device. So the question I have, and there was a recent publication actually in Circulation this year that was the results of the non-randomized study. This is actually the IDE that actually, the FDA IDE that actually allowed this particular defibrillator to get approval. And in this particular study, there were about 300 plus patients that were enrolled that received the device. Interestingly, 13% had a previous transcutaneous device that was before receiving this one. And the success rate for defibrillation was extremely high in this study. But of course, there were only a small number of patients, 38 episodes and 21 patients over the time period of 6-month follow-up that actually received, that had spontaneous tachycardia and received shocks. And this was successfully converted in all the patients. So the early study suggests that the SICD is safe and seems to be effective. That's what we know. And I'm just wondering, in the context of MADE RIT, what do you think is the role of the SICD? Let's start with you, Andy. We're going to work both ways.
Okay. By way of disclosure, I work with Boston. We were investigators. And that being said, I think it is a great addition to our armamentarium, and I say it for this reason, or for these reasons. The primary prevention trials that were done were all done for patients who did not have a pacemaker requirement for bradycardia, and they all would have been appropriate for single-chamber devices. Number two, to make the argument that having an atrial lead decreases inappropriate shocks, I think is wrong. All the large analyses that have been done show that the inappropriate shock rate is 10%, irrespective of discriminators and what atrial detection does. If you buy all of that, 80% of devices that are implanted in this country are for primary prevention, and they're split, unfortunately, to be 20% single chamber, 40% dual chamber, and 40% BiV. And in fact, of the BiVs, in an analysis that I did actually, over 20% of those people didn't even have an indication for a BiV, much less a dual chamber device. And that's in people who are 80 years old and greater. So there is a huge population who are candidates for single chamber devices, and as I showed at noon, even in AVID, which was secondary prevention, 75% of the people never used the device. So to have a subcutaneous device that doesn't pace the ventricle and doesn't do ATP is just fine. Furthermore, since it takes about 45 seconds for the SICD to deliver therapy, it fits in perfectly with what we've learned from MATE at RIT, that having a long detection time
It's not a bad thing.
means that you can have many, or there are many arrhythmias that would be shocked by a transvenous device programmed to nominals, that these arrhythmias will stop on their own. So I think it's got a place based on clinical trial entry criteria for single chamber devices. It's got a place because most people with the devices never use them. And number three, because it's got a long charge time, it can avoid shocks that are not needed.
So I'm going to describe two patients really quickly, and I'd just like to hear what you would put in each patient. The first is a 35-year-old patient with long QT syndrome who survived an episode of polymorphic VT. And the second is a 65-year-old patient with a previous myocardial infarction and ejection fraction of 28%. Who's presenting for a primary prevention ICD, has no indications for pacing. So it's two different populations. I'll start with you, Srini.
So the second patient, the first patient, no indication for pacing, or
Neither one have an indication for pacing.
Yeah. If there's no indication for pacing, the first one certainly a subcutaneous.
What's your reasoning?
The age,
Young
35
patient.
years old. You're talking about having an intravascular, otherwise having an intravascular dwelling leads for the rest of their life. Which
Just to bounce off that, the channelopathy arrhythmia patients are difficult, and especially the long QTs, because if they are younger and bradycardic to begin with, I do believe that there's a place for atrial pacing in those individuals. So if it's a woman and they're starting with a heart rate of 50, they've had their rest, they're not on a beta blocker, I would probably go with a transvenous device.
Yeah, I agree. That's why I was asking about the indication for pacing.
And I'll say also, this is maybe a side comment. What we did with those, or what I've done with those patients for years, is to atrial pace them at 80 beats per minute, beta block them, but I don't turn on ventricular pacing, because if they, and especially with rate responsiveness, because if they develop Wenckebach, they get a long short.
Yeah.
And I don't program on, I don't V-pace because they don't have to, but I don't put on rate responsiveness in the A because they'll Wenckebach. So I just fixed pace them at 80. And then if they go above 80 when they walk around, that's fine because they won't Wenckebach. But if you have the R on, that can be a problem.
What about my other patient, my 65-year-old,
primary
primary prevention post-MI?
Great patient for an SICD.
Okay. I want to move on. As usual, I'm running out of time here. But I want to touch a few other things. This is actually really interesting. There's a publication in Heart. It just came out online end of January. A single center sort of study. What they looked at is their own experience. This center was trying to ask the question, what is the incidence of tricuspid regurgitation related to lead implantation? I mean, we've all seen a couple of these patients. But what's the real incidence? So they looked at their cohort of almost 300 patients who either received an ICD, in fact, the majority had received an ICD, 239 had received an ICD, 48 had received a pacemaker, and they looked at the echo before implantation and after implantation, about mean of 1 to 1.5 years after implantation. So pre-implantation, 1/3 of the patients had no TR, 2/3 of the patients had up to 1+ TR, so mild, 1 or 2+ TR, so relatively mild TR. After implantation, significant TR, which is greater than 2+ TR, was seen in 38% of the patients. I was actually surprised at this data that it could be that high. And I'm just wondering, when we start thinking, in addition to the SubQ ICD, we now have, at least investigationally, we have leadless pacemakers. And I'm wondering, is this something we should be really worried about? I mean, 38% have worsening TR, or is this something that is maybe a little bit overblown? It's a number that doesn't mean clinically that much. Let's start with Sean.
Yeah, what was the time course when they re-echoed?
So the re-echo was about 1.5 years after the initial implantation.
I've been underwhelmed by the number of cases where you can prove that it was the ICD lead that was causing the tricuspid regurgitation. And more often than not, it's remodeling of the right ventricle with separation of the free wall from the septum. And when that happens, it looks like as if the ICD lead is impinging the septal leaflet, but in reality what's happening is that the rest of the RV is just remodeling. And that's the mechanism for the tricuspid regurgitation.
So you think it's just an epiphenomenon? We're not, so until we do a randomized trial of regular leads versus leadless pacing, we're not going to know the answer.
Yeah, and I think you have to control for the patient population. So if you're talking about a group of people that have a dilated cardiomyopathy or ischemic cardiomyopathy to begin with, you're going to see more RV remodeling.
It's interesting. And those patients that had more remodeling, that 38%, actually showed a subsequent higher mortality compared to those that didn't. But again, it could just be the underlying substrate. So interesting, but doesn't affect your management at this point. I want to, in the last remaining time, I want to just touch one last area, which is CRT. And there's one interesting trial that came out in 2013, late 2013, which is the ECHO CRT trial. Now, all of you know, in terms of therapies for heart failure, at least as far as device therapies go, CRT has been one of the most extraordinary therapies for those patients who have wide QRS. Not only does it decrease heart failure hospitalization, it decreases mortality. So given that extraordinary result, people have been trying to see what other populations may benefit from CRT. We had Rethink about 5, 6, 7 years ago, actually, I think. Rethink that looked at all patients who had narrow QRS and randomized them to either defibrillator or well, actually, they all got CRT, and the CRT was either turned on or turned off. And there was, not surprising, there was no improvement in mortality. ECHO CRT said, well, we know that there are some patients based on echo imaging that even though their QRS is relatively normal, they seem to have dysynchrony. And the question is, could these patients benefit? So ECHO CRT was a very large randomized trial, 115 centers, and it was supposed to be a very big trial. It actually got stopped early. But anyway, it looked at patients who had class 3 or class 4 heart failure, reduced ejection fraction, 35% and less, and a QRS duration that was less than 130, but had echo indices of ventricular dysfunction. And so the question was, would CRT improve outcomes? And actually, the study was stopped for futility. At the study closure, there were 809 patients that were enrolled. And as compared to CRT, if you look at the primary outcome, which was mortality or heart failure hospitalization, the hazard ratio was 1.2, so favoring control, not CRT. And interestingly, if you look at all-cause mortality, the hazard ratio was 1.81, favoring control. So CRT in this heart failure population with a relatively normal QRS, but echo indices of something, actually worsened mortality. Is this the nail on the coffin for CRT for these indications?
I think it's nail in the coffin because this isn't the first study that's shown that. This is one of many that has correlated QRS duration to outcome. And in fact, in reverse, Mike Gold has published that for people with QRSs of 120 to 138, that for CRT on in those individuals, actually outcomes were worse than control. And so this is just totally in keeping with other large trials in this area.
So let me ask you, I'm going to ask everyone. Take the patient, a 79-year-old patient with heart failure class 3, and with heart failure class 2 heart failure, and a QRS duration of 130, and an ejection fraction of 30%. So this is a patient, and non-ischemic, So,
a woman, you're trying to...
What's that?
And a woman.
And a woman.
Chance for response.
Sure. So I guess the question is, I just want you to think about and just help us understand, in these patients whose QRS is not particularly wide, can you just talk about the different criteria that you think about when you think about CRT or no CRT?
Me or?
Well, let's start with Sean, actually.
Well, I always love to find the population that's most likely to be a super responder. So left bundle branch block, QRS duration greater than 150 milliseconds, dilated cardiomyopathy in a woman. Those have the highest rates of responding, and if you have right bundle, QRS between 120 and 150, male, ischemic, much less likely to respond. So I think the case that you presented, 79, woman, QRS 130, 135, didn't describe what the QRS morphology is.
Yeah, let's say it's left bundle.
So it may be appropriate. I think it gets a 2A, and by the appropriate use criteria, it may be appropriate to use in some circumstances.
Okay. Andy?
Yeah, this is where I think it's real important to the discussion at the bedside is where you are in your stage of life. How far do you want us to push this? What are the expectations of benefit? If it's a left bundle in the female, non-ischemic, and sort of in that gray zone, it's a 2A, and I'd have no trouble doing it. On the other hand, if this was a IVCD in the male, I think the chances of benefit are highly unlikely.
You know, the last issue I just wanted to address, I'm going to do it quickly, is elderly patients' age. So let's imagine the 89-year-old patient who had a remote myocardial infarction and ejection fraction of 25%, okay? Class 2 heart failure and a narrow QRS. So basically we're talking about a potential primary prevention ICD in this 89-year-old patient. Any thoughts?
Yeah, I would talk them out of it.
Okay.
Talk the referring out of it, too.
Any other thoughts?
I think I agree.
Andy? Oh, sorry, Sean?
Ask him how old her mother is and her aunts and her siblings and things like that. I mean, it's really difficult. There are some 89s who look better than 59-year-olds, so you have to make some estimate as to what 1 year survival is going to be.
Again, we had this discussion at lunch, and very nicely. I think any 89-year-old, even who is a good 89, the chances for competing causes of mortality are great, and I would not be enthusiastic, number one. Number two, if there are comorbidities, and as we talked about, frailty in the elderly, that person is not going to benefit. And then last but not least, you always have to be at the bedside and talk to people about what their wishes are and what their goals and expectations are. And there are many people who are in that age group who say, you know, if I pass away peacefully in my sleep, I'd be grateful. And this is where we have to treat patients and not ejection fractions.
So as usual, I've monopolized most of the discussion. If there are any questions from the audience, Mark.
Defibrillation testing at the time of implant for primary prevention ICDs. A lot of data coming out recently showing that there is no benefit. It doesn't predict the ability of the device to work at a later date. Do you test your primary prevention devices now?
Yeah, it's a great question. For those who couldn't hear, the issue is, do you do defibrillation threshold testing or defibrillation testing at the time of implant for primary prevention? I do, and I do it for several reasons. And there are two populations where I don't. Number one is I don't do it for people. No, that's not really right. I do it because I want to see if the system works. I do something that is different than a lot of people, and that is that I do programmed stimulation on everybody also for primary prevention devices. In ischemic disease, if they have no inducible arrhythmia, I program them in a single zone, rate of 200, and go from there. And my inappropriate shock rate for 20 years was 3%, which is just exactly like made at RIT, and it makes sense that if you have no monomorphic VT and you have a high rate cutoff, you're not going to get inappropriate shocks. I don't do...
And what if you have inducible VT?
Huh?
What if you have inducible VT during your initial EP?
And then I program according to
You program according to it. Okay.
VT is. I don't do program stimulation, long QT, and then hypertrophic cardiomyopathy because they don't have monomorphic VT with preserved ventricles.
And what about the non-ischemics?
And for the non-ischemics, I do program stimulation also because some of them have a scar and are inducible. We don't put in pacemakers and not test pacing capability. It doesn't make any sense to me. It never has. Maybe it's my age and upbringing, but I test just to make sure the system works.
Can I ask one additional question? Actually, similar to a patient on the service now. Patient comes in and has let's say a large MI, then has an indication for a pacemaker, and the belief is that the EF is not going to improve. And as an example, complete heart block, the patient, let's say, would benefit from biventricular pacing. I know it's not covered in the guidelines necessarily, but what are your thoughts about putting in a bi-VICD?
Again, this has been well vetted, and there are two ways that I can support my comments. Number one is in the appropriate use criteria document, which was published in January, it is perfectly appropriate to implant a defibrillator. And the feeling of the committee was that you don't want to do a second operation down the line and risk infection. And actually, in the Department of Justice investigation, they had 10 buckets, as it was called, that were looked at. And one of the buckets that was given a pass to implanting a defibrillator within 40 days was for the patient who had an indication for pacing and you didn't want to have to come back. The one thing that I would tell everyone is that what you have to do in that situation is write down in the chart why you are doing what you're doing. And if you say, this patient has had an MI, has an indication for pacing, I'm not sure if the ejection fraction is going to get better, and I'm going to implant a defibrillator because I don't want to do a second operation, I know of 0 instances where that physician or hospital has ever gotten into trouble. So write down why you're doing what you're doing. The documentation saves the day. It's best protection for you, and it's good medicine.
Roni has a question.
A brief question about infarct size versus ejection fraction. And to illustrate very quickly, 47-year-old guy comes to our office, gets on a treadmill, has a negative stress test with normal LV function 2 minutes post, has a VF arrest, and by the grace of God, we get him back within 40 seconds. Shows on CAT that he has a distal circ, EF about 50, and an MRI shows an infarct size of about 10%. Are we getting to a substrate? Can we talk about substrate of patients that are not just EF of below 35% and talk about infarct size as well as a risk factor?
That's going to be that question was tried to be addressed in a study in Canada that was shut down because MRIs weren't being paid for, and it's a shame that that question is not answered. Now, for your particular patient, I'd have to know a little bit more about whether or not the troponin, for example, was 3 when it was first measured. But if it was not measurable for a good EF and just a distal circ, this is where I would fall into that. I'm really not very good at being sure that that was the cause of the. Yeah. I would consider that a secondary prevention device, and I'd have no trouble recommending implantation there.
But this was during exercise, right?
2 minutes in recovery.
With ischemic changes?
With 0 ischemic changes. I'm simply want to see if you think you should substrate, if we should take a look at the subgroups.
Well, I mean, the world we live in electrophysiology is now intramyocardial scar, whether it's intramural, subepicardial, and so forth. And to me, it's like being a little bit pregnant. If you've got scar, you have substrate, and it doesn't make any difference if it's big or small. But for your patient, especially with no troponin, VF, not a culprit lesion, this is secondary prevention.
I'd like to run a case by you, just a quick case. This patient in his 50s, actually 60s, who presented with syncope to an outside hospital, and what they saw in telemetry was not only frequent monomorphic PVCs, but runs of non-sustained VT associated with lightheadedness and such. So he was transferred here for a question of defibrillator or whatever we wanted to do, ablation and such. So we do MRI. EF is 40%, and he's got a pattern of non-ischemic septal scar, but not a whole lot of scar. So how would you treat this patient?
Well, if you're going to tell me that here at Sinai they had 40,000 PVCs and all monomorphic, and you ablated them, and this might be somebody you could put a vest on, and then when you find that the EF is 50 after getting rid of this tachycardia-mediated cardiomyopathy, then I wouldn't put a device in. Okay. So I think it depends what the look of the Holter is, too.
So I'll give you follow-up on the patient. So we tried to ablate the PVCs. They weren't endocardial or from the aortic cusp, and they ended up being epicardial location, but we did not target that at the first procedure. So at that point, we put the patient on an antiarrhythmic medication, amiodarone short-term, send him home with a life vest. So one life vest I put on the patient. He came back 3 months later. The EF is 55%. No more PVCs on a 24 monitor. I had told him to take off the life vest.
Sounds good to me.
Okay, with that, I think we're going to go ahead and close. Thank you very much, the whole panel.